Joining us this evening. Thank you for coming to our monthly webinar. As I know most of you know, there's a lot of familiar faces on here. We do these webinars monthly, so if there's ever any topics you want us to cover, feel free to drop them in the box. As I had just mentioned, we're doing a little bit of a different topic clinically today, so nothing's off limits. So go ahead and put those in the chat box if you do have some suggestions. The best way to view the webinar today is in speaker view. So in the upper right-hand corner, you can click the view button and then select speaker view, and that'll give you a nice side-by-side of Dr. and PowerPoint. I just think it's the best way to kind of see all of what's going on during the webinar. As I had mentioned, your camera is off and you are muted for the webinar. You can utilize that question and answer box at the bottom of your screen. We will be answering questions at the very end. So feel free to drop them throughout the webinar so you don't forget your questions, and then we'll address everything at the end. There will be a promo at the end, so make sure you stick around for that, and we'll kind of talk about those specials. So welcome everyone. Our webinar topic today is specifically on non-odontogenic toothaches and the clinical guide for dentists. So I do see a few new faces though. And so for those of you who may not be familiar with True Function, we are a specialized laboratory based in San Diego, focused exclusively on sleep apnea and TMJ appliances. And this year, we're proud to celebrate our 26th anniversary. So we take great pride in employing some of the most skilled technicians in the industry, ensuring that we deliver the highest quality appliances at every delivery. Should we identify any concerns that could impact the quality of delivery, we prioritize transparent communication. So with our 7 business day turnaround, our goal is to support you in treatment for your patients as efficiently as possible. So we're very grateful to have you this evening and appreciate your commitment to expanding your knowledge in sleep and TMD, and of course, in other areas. I'd like to introduce a new face here with one of our friends at True Function, Dr. Giosia. Doctor completed a residency in orofacial pain at the University of Kentucky Orofacial Pain Center under the mentorship of Dr. Jeffrey Okeson, as well as an orthodontic residency at the University of Cagliari, Italy. He is a diplomat of the American Board of Orofacial Pain, a board diplomat of the European Academy of Dental Sleep Medicine, and a fellow of the American Headache Society. Currently, Dr. Giosia is a clinical associate professor at the Indiana University School of Dentistry in Indianapolis, where he is responsible for clinical care and teaching in orofacial pain and dental sleep medicine. He also maintains a part-time private practice in Zionsville, Indiana, dedicated to the management of temporomandibular disorders, chronic orofacial pain, snoring, and obstructive sleep apnea. Before joining IUSD, he served as a clinical associate professor at the University of North Carolina at Chapel Hill. So we're so excited to have you join us this evening and share your knowledge with our attendees. So I'll pass it over to you, Dr. Giosia.
Thank you, and thanks for the introduction. Hopefully you can hear me well. And I want to thank again True Function, because I've been a client for a few years, but I want to thank you and Frank for also the dedication for the education, because again, this topic has nothing to do with appliances. So I'm going to talk about, so it's definitely very different. There is no lab involvement in this topic. So I really appreciate the commitment to education. Absolutely. And thanks for the introduction, and thanks for all our guests tonight. And as Tricia has said, I am a full-time clinical associate professor at the Indiana University School of Dentistry, where I teach orofacial pain and dental sleep medicine to the dental students, to the D3, and also to the D4 with some elective. And I am also, I have this very small part-time practice for now in Zionsville. So my idea tonight is to give a very broad overview of this topic, because I think it's very, very important for all clinicians, all dentists. Now, if there are any orofacial pain specialist colleagues in the audience, maybe it will be too basic for you, so hopefully it will be a good review again. But my target tonight was mainly kind of a general dentistry population, colleagues in general dentist and other specialty. So just to make them aware of, and maybe you already know part of it, that sometimes a toothache is not a toothache, and give you an idea of the few things, the more common thing you should be suspicious of. And then, of course, if you are interested in the topic, educate yourself more other than this, 45 minutes presentation, and manage this patient, or maybe refer the patients to an orofacial pain provider in your area, because they require, some of these patients pharmacological management, and usually those are not medication prescribed by general dentists. So, and at the end, I will be happy to take any questions. Let's see if we can. Good. So for the non-orofacial pain specialist, recently since 2020, I always have this slide, because again, I've been in the field for many years. So when this thing happened, I was kind of happy, relieved. So in 2020, our specialty, the orofacial pain, became the new officially recognized specialty. Again, it was in April 3rd, 2020. So it's not been so, even though orofacial pain residency program in the US has been around for many, many years. And I completed mine almost 20 years ago. And for, again, the non-orofacial pain colleagues in the audience, if you need a referral in your area, like if you need, you have one case that say, what, this one looks something like, I heard, during the webinar, maybe I want to refer this case to an orofacial pain specialist. You can go on the on our board website, the American Board of Orofacial Pain, abop.net, and there you can find a specialist in your area by the usual CD or state or zip code. So all the material I have in this presentation, and actually much more than that, I got them mainly from my mentor, Professor Jeff Oxen's textbook, the 7th edition, the Bell's Orofacial Pain, chapter 12, and a more recent paper from a very nice review, clinically oriented paper. And again, I'm going to keep tonight very clinically oriented. I'm not going to dig deep in the basic mechanism, the neurophysiology and all of that. You can definitely, I'll give you more information at the end where you can look for more education by yourself. But also that's a nice paper, I guess 2020. So a few years ago from Anton Delat from Belgium. It's a nice overview. I think again, for clinician, it can be very helpful. So the objective is just to give you an idea, recognize the most common causes of non-odontogenic toothache. Again, this patient that comes to your office and tells you my tooth is painful, you take a look, you do your usual, the x-rays, the clinical exam, and you feel like there's nothing wrong, teeth is fine, there's nothing wrong with the tooth. So at that point, you have to become suspicious. You say, maybe it's one of this, and I will do again, I'll give you the idea about the 5-7 more common causes. And of course, I'll try to highlight the key diagnostic features and the clinical presentation that you can apply in clinics, and also give you an idea how we manage these patients. Of course, I don't want to give you a cookbook or recipe, because cookbooks, I don't like them much, especially when it comes to medicine. But at least I'll give you an idea of what it can be done, kind of pharmacological management, you can do it. And again, if you don't feel comfortable prescribing those kind of meds, please refer to, as I will show you, to orofacial pain or to neurology. It's also a very good referral. Okay, so as a first, the first few slides, I just want to make clear the distinction, a very important distinction between the site of the pain and the source of the pain. So we are talking about referred pain. So the site of the pain, that's an important concept in orofacial pain, especially in chronic pain. So let's say the site of the pain is where, the patient comes to your office, doctor, I have pain in my upper right molars. I don't know. That's where he tells you, where he feels the pain. The source of the pain is actually the area of the body from which the pain actually originates. Now, if you talk about primary pain, usually site and source are the same, okay? So again, the patient comes to your office, oh, tooth is killing me. So, okay, let me see, open your mouth. You see there's a big decay, you take an x-ray. Yeah, no, why? You got a big, lesion, decay going to the pulp. That's why you have pain, okay? So we can take care of that. But sometimes site and source are different. So the patient tells you, I have pain in my upper, tooth or in my right TMJ, but the pain is coming from another area. So if you see these slides here, I have a better slides coming up, short video. So let's say that in this case, the patient is telling you that, he has pain in the right, in this left TMJ area. But if you see here, actually the source of the pain is from the shoulder, because, this goes back to the referred pain. I don't know if you remember the basic anatomy of your spinal trigeminal nucleus. You have the supranucleus, you have the convergence of the first order neuron and the second order neuron. I have a nice video coming up. It's better a slide, but as you can see here in the right, in this red second order neuron of the shoulder, you got also information from the green neuron coming from the TMJ. So sometimes the brain can get confused, and the patient is complaining about pain in the TMJ area, but the pain is coming in this area from the shoulder, from the neck. Okay, just to give you an idea, I have this. So this one is called the convergence. So it's mainly more nerves that carry input from tissue located throughout the head and neck can synapse in the same spinal nuclei. So it looks at this one. You have C2 converging on this spinous nucleus caudalis and interpolaris, but also you have this neuron from V3 giving information to the same blue neuron. So in this case, the patient will complain about TMJ pain, but actually the pain is originating from the shoulder area. That's a classical mechanism of referred pain. And yeah, and I like this. This one is from Dr. Åkesson. He gave me many years ago when I finished my residency. I said, Dr. Åkesson, you give me this slides I've been using since then. Just let me show you one thing. Let me light up all the small things here. So let's see. Okay. So in this case, if you look at this one, so the patient comes to your office, doctor, my tooth is painful. So the tooth, of course, this one is V2. So you can see the neuron is here. It's blue. Okay. So you got the first order neuron going from the tooth to the trigeminal spinal nucleus. And then you got the second order. If you follow the blue, it goes from the spinal nucleus to the thalamus. And then the third order neuron goes to the thalamus, to the cortex. And of course, you feel pain only when the signal reaches the cortex. But in this case, if you look at this one, you also have the green neuron, the first order neuron. That's the neuron from the temporalis muscle in this case. It's giving information, yes, to the second order green neuron, but also converging on the blue neuron, okay, the second order neuron. That's the neuron of the tooth. So that's why at this point, the patient is complaining about, pain on the tooth area, but actually the origin of the pain, the source of the pain is the temporalis muscle, okay? So that's the, it's way too simple, but just to give you an idea, again, that's the man with 3 neurons, but that's the mechanism of convergence, okay? That's one of the possible mechanisms why we have referred pain. Another mechanism, I'm not gonna go deep in that, is called the central excitatory effects. So it's mainly, you get repeated nociceptive inputs, so you can have activation of the higher centers, and you have the same phenotype, same presentation. So a patient tells you they feel pain in one spot, but the pain is coming actually from another area of the body. So please, this one is very, very important, because sometimes if they tell you I have pain in my teeth, you say that, listen, there's nothing here that you don't have pain. It's impossible. So, well, it's possible, but it's not a primary pain. So again, remember the site and the source of the pain can be different. And that's why at that point, you have to start thinking where it could come from. Because remember, if you want to be successful with your treatment, you have to target the source of the pain and not the site. Because if you keep doing, oh, maybe, yeah, the tooth, yeah, maybe let's see, maybe there is something you'll do, keep, root canal, maybe it needs a root canal, and then after root canal, say, well, you know what, it's still painful, maybe it's too short, let's redo it. And then at the end, you pull the tooth, and patient wishes the pain, okay, because you are trying to manage the site of the pain, but there is nothing wrong with the site of the pain. The thing is, you didn't get the source of the pain, because again, if you want to be successful, that's where you have to get through, okay? And we'll see for each of the referred pain mechanism and reason why they can have pain. So that's a kind of a laundry list of the most common non-odontogenic toothaches. So you can have patient complaining of a toothache. The problem is not in the tooth, it's actually in the muscles. Myofascial origin, and usually for toothache, those are mascatory muscle pain origin. I'll show you a couple of slides. And then you have toothache of neuropathic origin. So there is something wrong with the disease or some lesion or disease with the nervous system. Neurovascular origin, like toothache coming from the classical, the most common clinical condition as a neurovascular pain condition, it's a migraine, okay? So it's mainly a headache, but as we'll see, sometimes, they don't show up in the usual location of the headache, but they can show up in the face or in the teeth, on the tooth, okay, or teeth. So that's why. And then, of course, toothache of cardiac origin, sinus, a nasal mucosa, we all know about that, you especially from the sinus, you can have pain in the upper teeth. The problem, again, is not the teeth, it's in the sinus, okay? So first in line, actually probably one of the most common I see in my clinic of this patient coming, complaining about toothaches, and usually it's not usually one tooth, so like more teeth. And they've been to the dentist. This dentist says, listen, there is nothing there. Sometimes they've been to the dentist and they pulled one tooth or they did some extraction and they still have the pain. This is very, very common. And so it's mainly toothache originating from muscles, from muscle pain, musculatory muscle pain. If you're familiar with the definition, it's muscle pain characterized by trigger points. So a trigger point is a hypersensitive spot, usually within a thought band of the skeletal muscle. That it's painful on stimulation. It can also cause referred pain. Now, this condition is kind of debated condition. You always have, especially on our listserv, trigger points, they don't exist. Oh, no, they do exist. But there are a lot of things behind it. Definitely something we see in clinic. And honest with you, it's being also one of the most common. It's actually quite easy to trying to find out, okay? Because, if you are suspicious of that, you don't need any special tools or machine. You just have to do a good muscle palpation and ask the right questions to the patient and see if you can increase the tooth pain to the patient just touching the muscles, okay? And this is actually, I see quite a lot. Back in the days, many years ago, again, this Dr. Travel, they did a map of all the referral of the muscle in different area of the body, not only of the head and neck, all the muscles of our body. Again, kind of a debated condition, but it's definitely something we see in clinic a lot. I mean, we can debate on the mechanism, but that's definitely, we see this all the time. So as you can see, for example, here, if you have your master muscle with the trigger points, the black axis here are representing the trigger points, they can refer pain to the upper and lower teeth. And they can actually refer pain to the TMJ area, but focusing on the tooth here. So as you can see, master muscle, upper and lower teeth, mainly posterior. Temporalis muscle, it's mainly upper teeth, anterior and posterior. The digastric muscle is mainly the lower incisors. Like everything in life, nothing is clear like in the textbook, in real life with patients. So just get your information, and it's definitely there, but don't be, it cannot be that because, you didn't tell me in the lecture, in the webinar. You have to be a little bit flexible, but definitely that's one condition you should always consider. When you have a toothache that doesn't look like a toothache to you, and that's the first thing you should hunt for, just, is this coming from a muscle? And again, you just have to know how to do a muscle palpation and find out if palpating the muscle, you can make the toothache worse. And of course, in this case, you want to manage the muscle. You don't want to touch the teeth. Because again, the problem is not in the teeth. They complain about tooth pain, but the problem is in the muscle. Okay, that's usually a characteristic. Just to have an idea, again, it's not always black and white. There are a lot of gray areas, especially in pain. Diagnosis and management, but usually it's kind of a constant, dull, achy, non-pulsatile, kind of pain. Is not responsive to local provocation of the tooth. Your percussion. Those are the trigger points. In the muscles. The toothache, of course, increase with function of the involved muscle because of the trigger points, and palpation and provocation of the trigger points increase the toothache. That's also, when you take a pain history to your exam, you don't want to feed the patient with their answers. So I won't usually what I tell them, listen, I'm going to do some palpation in your jaw muscle to do a complete exam. Please tell me if when I do that, of course, it's going to be maybe a little bit of discomfort, but tell me if you feel pain only when I'm pushing it, when I'm touching your muscle, or if you feel pain somewhere else. And at one point, if they tell, yes, I feel it somewhere else, and at that point, you can ask, am I making your toothache worse? Just you want to make sure you can increase or reproduce the toothache of the patient. And of course, if you do a trigger point injections, it does reduce the toothache. You inject the muscle and the toothache gets better. Sometimes it's quite kind of impressive, for the results. And the patient at that point understands that the problem is not in the teeth, it's in the muscle. And for the management, of course, in this case, is like managing a TMD, like a muscle pain patient. Of course, every patient is different. You have to, tailor the treatment to the patient, but all the techniques and things we have for muscle pain management, spray and stretch, trigger point injections, physical therapy, that thing helps a lot. But self PT or referral to a PT who knows how to manage, head and neck and TMD patients. We can do also some short-term pharmacological management. Be honest with you, if I use mainly NSAIDs. I don't use much muscle relaxant. Tricyclic can be helpful, especially when you go into chronic pain. Botox, between parentheses, of course, it does help. I wouldn't jump on this as a first-line treatment. I will try, definitely trigger point injection and other things at the beginning. Of course, if it's, we are talking about muscle pain because of overusing the muscle, also a splint can be helpful for night. But as you can see, you don't touch the tooth. That's the main thing, okay? Because the problem, he complains about toothache, but the problem is not in the tooth, it's somewhere else. In this case, it's in the muscles, okay? Second in line, we have toothache of neuropathic origin, okay? And there are two main, as I'll show you, neuropathic pain conditions. So neuropathic pain, by definition, it's pain arising mainly as a direct consequence of a lesion or a disease affecting mainly the nervous system. So disease, it can be like diabetes or stroke. Lesion, it can be a lesion of the nerve itself, as you will see. Mainly neuropathic pain is the result of injury or disease of sensory nerve fibers due to different causes, including toxic, traumatic, ischemic, or metabolic or compressive damage, okay? That's the definition of neuropathic pain. Now, from a clinical point of view, you can divide this neuropathic pain mainly, just to make your life easier clinically, in episodic pains and continuous pains. Like, the episodic pain, as the word says, it comes and goes. And the patient tells, oh, yeah, it hits me, and then it goes away, and then it can come back sometimes 10, 15, 20 times a day, or, 2 or 3 times a week, depending from the condition. So, but usually between one episodes of pain and the other, the patient is pain-free. Or you can have continuous pain, it just never goes away. Usually it's not as intense as the episodic one, as we'll see, but it never goes away, okay? So that's some very nice kind of a review paper of this trigeminal neuropathic pain a few years ago. As you can see here, you have in this, the one on the top, those are the episodic pain. It's mainly when we talk about, our field of, dentistry, we mainly talk about trigeminal neuralgia, as we will see in the next few slides. Mainly, those are recurrent unilateral, brief electric shock-like pains. And I'll give you the clinical features more in detail. And of course, TN, if you can also divide in classical trigeminal neuralgia, secondary TN, or idiopathic TN, okay? And again, if you want to know more, please, review this paper and the next one I'll show you. That's, again, the episodic neuropathic pain, and again, in our field, the trigeminal neuralgia is definitely the most common. And then you have for the continuous neuropathic pain, those are mainly continuous or near continuous pain, commonly described as burning or squeezing, like pins and needles. And you can have some, on top of that, some brief paroxysm of pain, but it's always there, okay? And tonight, I'll mainly mention one condition. That's probably one I see, quite a lot. It's called the painful post-traumatic trigeminal neuropathy, okay? Let's see, show that. So again, episodic, you got this episodic neuropathic pain characterized by periods of very intense pains followed by total remission. So this one being trigeminal neuralgia, maybe you are talking with the patient, is doing, looks very good, talking, all of a sudden it just stops and holds his jaw because he cannot talk. So you get these very intense episodes of very, very severe electric shock like pain. But usually at the beginning, if it doesn't have the classical manifestation, at least in the beginning, between one shock and the other, they are pain-free. Of course, I'll show you, they can trigger it. So usually, again, very severe trigeminal neuralgia, if you ask them from 0 to 10, 0 being no pain and 10 very severe pain, how much is the pain? They tell you it's 100. I mean, it's very, very painful, okay? It's unilateral paroxysmal shock-like pain felt in a tooth in case, or Usually it's more than one tooth. The pain is, they have one features, and I'll show you a nice paper with a nice picture. They have a features of having trigger zone. Okay, please do not confund the trigger zone with trigger points. They're completely different area. So they mainly have areas that can be inside the mouth or outside the mouth. They touch this area, just touching. I'm not talking about pushing, just touching sometimes. They can trigger the shock-like pain, okay? And the trigger may be a tooth also. So that's why sometimes it's confusing for us dentists, because oh, I have this thing, if I touch this, it's very, very painful, as I'll show you in the next few slides. And there are pain-free periods between episodes, at least if they don't have the overlap of the background continuous pain, okay? As a features of trigeminal neuralgia, sure you're familiar with them. Again, very recurrent paroxysmal unilateral pain in one or more division of, usually it's unilateral, it's one division. The pain can last from fraction of a second to a couple of minutes, very severe electrical, and this important feature is triggered by innocuous stimuli within the affected CN5 trigeminal nerve distribution. I'll show you a slide, okay? Mainly three categories, the classical TN, it's mainly, sometimes it's because of neurovascular compression, in the brain of, superior cerebellar arteries pushing on the trigeminal nerve. You got the secondary TN. It can be secondary to something, like, for example, secondary to MS, multiple sclerosis. MS patients are 20 times more likely to have TN, secondary to tumors, or idiopathic. So you understand, because of this possibility here, if you feel like, oh, it sounds like a trigeminal neuralgia, you want to make sure they don't have something going on in their brain, either, like a multiple sclerosis or a tumors or something pushing on the nerve. So that's why all the patients with trigeminal neuralgia, they need a brain MRI. So that's why in this case, I think, unless you're, again, an orofacial pain specialist or someone really dedicated to orofacial pain, I think you have to refer these patients because you want to make sure they don't have something much more dangerous than, of course, than, pain, and like, again, MS or tumors. Again, they all need a brain MRI. Okay, and there are mainly two main phenotypes, trigeminal neuralgia with paroxysmal pain only, and you can have TN with paroxysmal pain and some sort of concomitant continuous pain. That's the paper I was telling you. That's a very nice paper. I found it very, very helpful also for, clinician, like we all are. 2020 New England Journal of Medicine. It's a group of neurologists from my home country, Italy. Very good, very well, very nice group. Actually, one of them, Dr. Truini, also was my guest when I organized during the COVID, at the beginning of the COVID, you remember all those webinars. I did a series of webinar when I was at UNC, and it was one of the speakers. Very, very nice speaker. And this paper, it's very, very nice paper. I think you should definitely read this one, okay? Again, if you're an orofacial pain specialist, maybe it's too basic, but it's a very nice review paper. What they did mainly, they had around, if I remember, 120 patients, okay, with classical trigeminal neuralgia. So they divided the trigger area and the specific movements that can trigger the pain. As you can see, the trigger area, like you can see here, activities of daily living. If you look here, just talking, washing the face, chewing, so it can trigger this electric shock like pain. And specific movements, if you look here, gently touching the face can trigger the shock like pain. Now, in the picture on the side here on the left, you can see they kind of did an overlap of all the area where they are the most common area of the trigger area, touching the face. Look, the yellow area and the red area, of course, you got more prevalence. Those are, it's very common areas, extraorally. In fact, sometimes, women, they cannot put makeup because I cannot touch my face because I trigger this terrible pain. Men, sometimes they have difficulty in shaving because of it. And as you can see, you have triggers area outside, but also inside the mouth, intraoral. And this one sometimes can be, at least once a month, I get one patient with one or two teeth pulled and they still have pain, and it's trigeminal neuralgia. So, but this one, once you know the features, and especially if you watch some YouTube videos of patients with trigeminal neuralgia, I mean, once you see one of them, you will recognize them. And sometimes I think you can diagnose this by phone, even without, seeing the patient. But definitely, please, also YouTube, Google or go on YouTube, Tragenial Neuralgia clinical presentation, you will see patients and they do all the same thing. They're talking to you and then all of a sudden they stop because they're very, very severe pain. But I definitely recommend this paper. And those are the official features classification, at least the IHS classification, the International Headache Society, very nice website also for all the classification of the headaches and, cranial neuralgia. So please, it's free, so you can definitely look at that. So that's mainly what I told you already. I just put you for your reference. And those are, again, the features. Lasting for a fraction of a second to a couple of minutes, very severe intensity, electric shock, like, again, that's something that they will tell you. You don't ask, what kind of, if you ask, how would you describe the pain, the quality? And they will tell you it's kind of electric shock. It's the classical definition of the patient. And again, one of the point for the diagnosis, it's precipitated by innocuous stimuli within the affected trigeminal distribution. Okay? So how do you manage this? What do you do for these patients, with patient with trigeminal neuralgia? As I said, they need a brain MRI, so refer to a neurologist or to an artificial pain specialist. Usually the first line treatment for this patient is, medical management, pharmacotherapy, and the class, usually the most common is the anticonvulsants or the antidepressants. I would definitely say anticonvulsants. One of the most, probably oldest, but still used, anticonvulsants. I'm sure you know the name. It's carbamazepine. They work. They do have, for a good number of patients, they do get some relief from medication, but medication can have side effects. So definitely, if you are not used to it, don't start prescribing it, of course, because the side effects, they have to be managed, your blood work has to be done. So, but just to give you an idea that the first line usually is pharmacological treatment. Now, for this pain condition, for this trigeminal neuralgia, there are surgical options, especially if it's a classical trigeminal neuralgia with the neurovascular compression, meaning one blood vessel is pushing on the trigeminal nerve. The neurosurgeon can do what they call a microvascular decompression. It's mainly a brain surgery. They open up the skull and they mainly put like a little sponge, in between this blood vessel and the nerve. And it works. But of course, not all the patients are candidate to the surgery because, of course, first they do an MRI and an MRA, see if they found this neurovascular conflict. And but definitely there are surgical options for this kind of pain condition. There are other more, if you want, peripheral options, usually performed by pain management anesthesia. There's a gamma knife, also an option done by usually radiology, interventional radiology. So there are, just to give you an idea, there are surgical options for this condition. Again, doesn't mean all the patients will be candidates, but there are options. And sometimes they do work quite well, okay? On the other end, for the continuous neuropathic pain, mainly as the word, says, it's always there. And one of the features, again, please remember, is not always black and white, but this one usually it's described as a burning sensation, okay? They may fluctuate in intensity, but no periods of total remission. So they always have something there. Now, the trigeminal neuralgia, usually, again, the intensity is very, very high. This one is not as bad, but it never goes away, okay? And if you hear the word burning, it should be, suspicious of, a neuropathic pain condition. So the clinical characteristics, of course, pain in a tooth or a tooth site, very, very common. It's the classical thing of a perfect root canal. It's fantastic, like textbook root canal. It's done by, your endo colleague with, microscope. It's perfect. But they say, listen, my tooth is painful. And even though they should be painful. And then the classical story is, oh, maybe it's too short. Let's redo it because they go to another endo. And then, I don't know, maybe do the apicectomy. But yeah, maybe. And then, doctor, is still painful. Okay, let's pull it. Okay, so they pull it, they pull the tooth, it's still painful. Okay, so that's the classic, the most common thing I see of the continuous neuropathic toothache. Okay, or again, if the tooth is still there, if not, pain in the area of the tooth. It's almost always there, burning, kind of achy. can be increased by local provocation because it can be tricky because they develop some other neurological complaints. They can have allodynia, meaning you touch, allodynia means like a stimuli that shouldn't be painful is painful. Like, you touch the face and or the skin is very painful, or you touch the gum and they jump, you touch the tooth because they have this, and I'll show you why. So they have other neurological complaints. Sometimes also they complain about, if they still have the tooth, of course, and they say, doctor, is something, the tooth is painful and there is something stuck in between the teeth. Also, the one in front, there must be something in between. You check, there is nothing there because those are neurological complaints. It's like any other neurological disorder. Okay, because that's what happened. Usually for a normal subjects, like say, you apply a stimulus, before you start feeling pain, you have to reach some sort of intensity of the stimulus, right? Now, when you have an injury of the nerve, like for example, extraction or a root canal, you have the system gets sensitized, so you have what you call allodynia in this case. So you touch the area, it shouldn't be painful because you're just lightly touching, but they feel, oh, it's very painful. They jump, or the tooth is more sensitive. So that's why it's again, this one is from a publication of neuropathic pain, not on our area, but all the neuropathic pain have several common features. Going back again to the classification of the IHS, the one I showed you for the trigeminal neuralgia, they also have the diagnostic criteria for this condition that you can also have different names. I'll show you another classification later on, but I still use this one, like this one. Painful post-traumatic trigeminal neuropathy. You can see the features, the diagnostic criteria. Now, trigeminal neuralgia, sometimes patients said, you ask, how did this thing started, the pain? I said, well, I don't know, it just started, And in this case, there must be a traumatic event. And again, the traumatic event can be, as you can see down here, mechanical, just cut, the nerve, like, if you think about root canal, chemical, after injection, topical injection, like anesthesia, thermal or radiation, okay? So there must be some event. So the pain started after the event, okay? And they can be, as I said already, they can have associated positive neurological, dysfunction like hyperalgesia or allodynia. So you touch it, it shouldn't be as painful, or negative, the other way, just hypoesthesia or hyperalgesia, okay? Of course, pain is to be developed in less than 6 months. It's not like, they come to you and say, this tooth is painful. I had this root canal like 5 years ago and it started being painful yesterday. That's not the case, okay? There must be also some sort of temporal kind of connection with that. How do you manage these cases? Being a nerve pain, like a neuropathic pain, like the trigeminal neuralgia, again, the pharmacological management is probably one of the first options. Anticonvulsants, still the same family, even though in this case, anticonvulsants like gabapentin or pregabalin, they are probably sometimes works better than the one that works for trigeminal neuralgia, being carbamazepine. Antidepressants, as you can see, the same family of drugs. Parenthesis, Botox, there are some case reports that, if you inject the pain, the area of the pain, may be resistant to medication. Sometimes, it gets better. And we do have some case series, again, not many big number of patients, but again, maybe something we'll know more in the future. In this condition, especially if it's a pain in a tooth or a tooth area, you can also start with topical medication. And topical medication, usually those are compounded gel. There are a lot of different recipes, for that's a nice review from Dr. Gary Eyre group. Gary Eyre has always been very active and has been using those topical compounded gel for many, many years. And I do too. I mainly have a couple of recipes that I use it, but very nice paper, please review it because it gives you a good overview, not only for neuropathic pain, also for other pain condition like muscle pain. And being intraorally, as you understand, every time you put something, it just, it doesn't stay there for too long, right? Because, saliva, you wash it, it's gone. So in this case, you can use like a stent, like a neurostent. You have a picture from the same publication. It's mainly something to hold the medication in place, because of course, it's not like you put the medication once, pain is gone. And you have to keep using it for a while, and hopefully it will get better. And please remember, when it comes to pain, as you can see in my slides, it's management, okay? Because sometimes you cannot get rid of it 100%. And as a dentist, usually we like to fix. In this case, you manage, okay? It usually gets much, much better, and the patient is very happy, but please. So again, pharmacotherapy and can be by mouth or topical medication. And again, please, this paper I really like it, very well done. Not many surgical options for this condition, okay? Or at least not many surgical options with evidence. So you got the muscle pain, toothache coming from the muscle, toothaches coming from nerve, neuropathic pain. And then you have toothache of neurovascular origin. Again, as the neurovascular origin, as I said, one of the most common neurovascular clinical condition, it's migraine, okay? So it's mainly a headache showing up in the face, or in this case, in the tooth, okay? Because if you remember, we said always that, it's, if you have pain, above this line here, you got a headache. If the pain is below this line, you got a facial pain. Please remember, it's one nerve for several mechanisms, including convergence. Sometimes headache can show up in the face or in the teeth, okay? Headaches, just, of course, it's not my intention to, I don't expect you become proficient in headache diagnosis with 4 slides, but just to give an idea, okay? So mainly primary headache and secondary headaches. Secondary headaches, again, secondary to something. The most common are definitely the primary headaches, migraine, tension type headaches. There's a group called TACs, trigeminal autonomic cephalalgia, and other primary headache disorders, okay? Usually the one that refers more pain in the facial area, on the teeth, it's either the migraine or the trigeminal autonomic cephalalgia, the TACs, okay? This slides, we should speed up a little bit, from this very nice book from Dr. Benoliel a few years ago, but still a very nice book reference. So, those are usually the usual location of the pain in migraine. It can be migraine can be also, bilateral or unilateral, but can switch side. Usually behind the eye, patients say, it starts in my neck and then moves up and then behind my eye with all the features of migraine. I have features in the slides, you can review yourself. That's the classical, headache presentation. Cluster headache on the other side, that's the classical presentation, around the eye or deep in the eye, but it can radiate, in different area. That's the paroxysmal hemicrania. That's another TACs, trigeminal autonomic cephalalgia, usually on one side, and also a SUNCT. That's another trigeminal autonomic cephalalgia that sometimes can be confused. It's almost very similar features to trigeminal neuralgia. Of course, most of the time is, different. It's the ophthalmic branch. Those are the TACs, and important things about the TACs. Usually they are side locked, okay? Always on one side. And of course, as the word says, they have a lot of very severe, usually autonomic signs. And as you will see in the next few slides, the way the patient presents, okay? This paper published a few years ago, 2019, it's a very nice paper, again, very clinically oriented. So those are almost 3,000 patients showing up in a headache clinic in Germany. So this, the light blue is the regular headache, so headache patient with just headache, okay? As a location, we will see there. Now you got patient with headaches and facial pain. So it's my terrible headache, but also my face. So now if you look at the patient with facial involvement, the prevalence of the headache in this case, as you can see, a lot of them, they had migraine. I mean, they were feeling facial pain because of migraine. And sometimes they feel toothache also, but because of migraine, okay? This one is cluster headache. See, those are the main, headaches. They were referring pain to the face, okay? And then you got the paroxysmal hemicrania, hemicrania continua, and SUNCT. Now, a small subset of them, they only had facial pain, okay? But the cause of the facial pain was, again, a headache, okay? And paroxysmal hemicrania, cluster headache, and migraine, okay? So those are very, very common referral to the face. I mean, headache that can cause face pain, and in some cases, a toothache, okay? In fact, many years ago, I don't know if you're familiar with Wolf, is one of the father of the headache medicine. He said, yeah, migraine usually starts in the, patient complains about pain in the temporal area, supraorbital, frontal, behind the eye. But he says also sometimes they can occur, this pain can show up also in the maxillary region, the upper and lower teeth. And we were talking about many, many years ago. So it's nothing new. And of course, those are the clinical features, and I'm not going to read them for you, of the classical headache presentation, like in case for migraine. We have a classification, it's called the International Classification of Orofacial Pain, ICOP. What they did also from Dr. Benoliel was one of the author of these guidelines. Orofacial migraine, so there's mainly migraine showing up in the face. As you can see, orofacial migraine, trigeminal autonomic orofacial pain, so you can see all of that, okay? Of course, we're not going to talk about this now. It's just beyond the features of this presentation. But please, if you're interested, that's a very good resource also to go in depth. As you saw already in the pictures, the most common headaches that can refer pain to the face or teeth are migraine or the stacks. The stacks, of course, are these three main headaches that I showed you in the pictures. Those are again, trigeminal autonomic cephalalgia. They have a kind of a shared clinical phenotype of trigeminal pain and autonomic symptoms, meaning mainly tearing and rhinorrhea. That's by redness of the eyes, can be kind of quite violent. The intestine is very severe, and the pain quality of attacks and dental pulpitis is similar. And dentists are often the first healthcare providers consulted. Not much in cluster headache, because cluster headache, honestly with you, is so severe that. But I've seen quite a few of paroxysmal migraine. Last one a couple of months ago. Okay. And those are, again, the clinical presentation, the classical of the cluster headache. But sometimes patients describe tooth-like pain and, can be misdiagnosed as a toothache. And those are all the features. This is the paroxysmal migraine. One features about this headache, and another one, the migraine continua. They respond, in fact, it's in the diagnostic criteria that, sometimes, it sounds like that, it feels like that, but I'm not sure if it's that. What you can do you can give them indomethacin, Indoxan, and almost like a magic thing, pain will disappear, okay? Of course, I don't recommend you become Indoxan, indomethacin for this patient. The goal of my presentation is just to make you aware that also headaches sometimes can show up as a face pain or as a toothache. So for you, if it makes you feel like, it's not a toothache, but it's not muscle pain, it's not neuropathic pain, it must be something else, maybe it's a headache, so you can refer, okay? That's the idea of the presentation. And of course, the management, it's mainly referral to neurology or orofacial pain. There are, again, the management usually is pharmacological, and for abortive medication or preventive medication, quite still few old medication, but also couple of new family of specific medication, especially for migraine, like for the abortive, the GPANs, or for the preventive, the monoclonal antibody. I guess that's the GRP. So just to give you an idea that there are options, and there are actually more options in the last few years. It's pretty good. Now, the next one, you have toothache of cardiac origin. There are studies. A few studies from Marcelo. It's a friend from Uruguay, Marcelo Kreiner. He actually did his PhD thesis in Sweden, if I remember well, on a toothache of cardiac origin. So what he did, he went through cardiac units and interviewing patient who had a heart attack or angina, and asking him to draw on the picture where he felt the pain, And if you see here, the classical, of course, as we all know, the location of the throat, the left mandible, the right mandible, the left TMJ area. But if you can see a small subset of them, it's only in the tooth, like a toothache, okay? So again, make suspicious in case, you have a patient that pain is kind of a deep diffuse toothache, increase with physical exertion. It's associated with chest pain, anterior neck pain, and shoulder pain. Of course, the symptoms of toothache can decrease after administration of nitroglycerin. How many have I seen? Not many. Hopefully, I didn't miss one. But definitely, they're not as common as, toothache of muscle origin or neuropathic pain or other conditions. Okay. Of course, in this case, if you're suspicious, the thing you have to do, refer. If it's something you have in front of in your chair, definitely ER or something you have to do like soon. You don't want a patient to wait if you're suspicious of some cardiac origin, okay? This one, I go very quick. We all know this, since dental school. Toothache of sinus origin, of nasal mucosa origin. Usually it's pressure behind, below the eye, pain increase with application of pressure over the sinus. Tooth can be sensitive to percussion, of course, mainly the upper teeth. Toothache is increased with lowering the head, and toothache also increased by stepping hard on the heel of the foot, walking down the steps. Again, you know this, I'm sure. And of course, in this case, if you feel like there's some sort of, sinus involvement, probably a referral to ENT is the best thing to do on the primary care, okay? As I said, this paper has been one of my reference for this presentation, so I think you can download it for free from the Journal of Rehabilitation from Dr. Delat. Very nice paper. This paper here, it's more recent, 2023, also from actually one of the two, from Dr. Benoliel, and also Ardemay was one. He was one of the author of the paper I showed you about headaches showing up as a facial pain, 2023. This one described not only toothache, but also other, orofacial pain condition that can be caused by something else. And again, very clinically oriented. So really recommend you take a look at this paper. And of course, for a more basic kind of intro, the classical books, I would say, yeah, that's the TMD book, probably not much, but I'll say the orofacial pain book of Bell's orofacial pain, Dr. Benoliel book, definitely, even though now it's still, we've been waiting for the new edition for a while now, but still, current. It's a nice textbook. And of course, our guidelines from the American Academy of Orofacial Pain. Those are my contacts, my IU email, and my practice email. And I think I did just right on time, even though I have to rush a little bit at the end. So sorry for that. And I'm done for the presentation. And I don't know if Trish, you want to just jump in, and I have another couple of slides that I can show after you join.
Yeah, absolutely. If you want to head over to the next slide, while I finish up these last two things, if you want to go ahead and put any questions in that question and answer box, or feel free to raise your hand and we'll address those in just a moment. So as you think of any in the next few moments, put those in that question and answer box or raise your hand and I'll unmute you so you can ask Dr. Giosia any questions that you may have. I know it wasn't quite focused on devices today, which is okay and wonderful. But if you do need help with any of those orofacial pain devices, as well as craniofacial pain, TMD, sleep apnea devices, we're happy to support your lab needs. So if you need anything, feel free to scan that left QR code and we're happy to help you, even if you just have questions on devices or anything like that. The QR code on your right is going to be for our next webinar, so we'd love to have you join for that one as well. Our topic specifically is going to be with Michael Cohen with Awaken to Sleep, specifically on hero positioning and mastering that communication and negotiation for your sleep patients, so more of a practice growth in the sleep area realm. So that webinar is August 27th. You can also find that on the education page of our website.